today. Next slide, please. We are here today. I'm going to do this welcome. My name is Joanne Jarvie, and then we are very pleased to have our partner, Nancy, from PointClickCare, Collective Medical Technologies, talk about a solution called the Emergency Department Optimization tool. And then after that, or even during, we shall have a dynamic discussion about why this is valuable and what we want to see in the future and what this has to do with health information exchange and next steps and steps that we took to get here. And also, this is my rodeo. So I'm going to say that if you feel so inclined, because you cannot even hold yourself, you're so passionate and you have to interrupt, like ask your question, because then they're going to move on. We're going to move on to the next slide. We might lose our whatever. Don't worry, just participate. Next slide, please. MyHIN. What is MyHIN? MyHIN is Michigan's digital infrastructure to support the legal, technical, private exchange of personal health information. Now, you can understand why the exchange of personal health information would need to be collaboratively governed. Where the pipes and the utility are not solely owned by one actor in a care ecosystem, but rather governed by payers, governed by the state, governed by hospital associations, governed by provider associations, governed by health systems and providers. We are an unbiased data trustee. We do not create this data. We move this data in ways so that it can be useful. We're constantly trying to advance outcomes, create lower costs. I just saw an amazing stat that I will be releasing soon about how Michigan's healthcare costs being the lowest in the country, probably because a lot of what we do is actually working. Altogether. Technology, though, has its place in the world, and it's a tool. It's a tool to support human beings. And please, let's keep it that way. This technology, health information exchange, is meant to support the ability to connect, to communicate, to collaborate, and to make informed decisions about people's care. Next slide, please. I am Joanne Jarvie. I am the Senior Director of Outreach and Market Communications. I talk a lot. I get to meet with people all the time. I'm constantly trying to explain why this work is important and take feedback and make our work better. But the way that I look at this work is that, yes, there's technical infrastructure. And today we're going to get into, solutions, a technical solution to a human problem. Basically, a process, maybe human problem. But what I have found is that, sometimes we have to be really specific about what the technology is doing. Is it meant to communicate something? What is it trying to communicate? Is it information or is it data? Sometimes data is not communicative. Really taking a step back and understanding that what will make this work, what will make anything work in a civil society, is trust between human beings, and that takes a long time, and it's the real work. Next slide, please. This is how I usually move through these convenings. This is it's called the group development model. And I was taught this model by our partners at MPHI with a grant from Michigan Health Endowment Fund. And so if I'm going to ask questions, Nancy, today of our guests, I'm constantly sort of asking why. What is the why? What is the why? Why? A lot of people want to get to the what, but the what is really not as important actually as the why. So the why, who, how, what. We're looking for feedback. Let's try and make our questions or make our answers sort of like, well, this is more of the who, or this is more of the why. Next slide, please. Again, wanted to remind you that in this role, we are acting as a neutral data steward. The goals of data stewardship are to act to make the data available, to protect the data, and to make sure that those that are making the data valuable, or for which the data is valuable, are collaborating. And so that should be my role today as well. Next slide. Last, at our download, I did a sort of 101 on our use case factory and how Myhin sort of looks at our work from the why are we exchanging this information. And the why are we exchanging this information is taken into bite-sized sort of modular use cases. The use cases belie our services and our solutions. So there are use cases that make this solution work in Michigan. And there could be new use cases that could even make the solution that we are going to learn about today work even better, perhaps. If anybody has any questions about that, we can get to it. Next slide, please. You are not here to see me, probably. You are here to see and learn from Nancy, who comes to us as a clinical solutions lead from Collective Medical Technologies, which is now a PointClickCare company. She was a registered nurse, which means that she's been on the ground, which is super important. She developed and implemented palliative care programs. She understands the importance of exchanging health information and making sure that you have the information when you need it. And I'm really looking forward to hearing from her, move through the whys, the whos, the hows, and the whats of this emergency department optimization tool. Nancy, over to you.
Thanks. As she said, I am a nurse by trade, so I tend to think in a clinical manner. To play off of kind of what you said, Joanne, I really do like getting into the whys and getting into the weeds of things, because what's the purpose if you don't know why you're doing something? So the technical solution to a human problem thing does come into play. I am going to start sharing my screen with you in just a moment here so that you can see what I am sharing. Okay.
Nancy, we can see your screen.
Yay, success. Love it. So basically what I am going to go over with you is just an overview of the platform that we are partnering with Myhin on to offer you to help with your EDO, emergency department optimization. So that's what we call it, as EDO. And then I'm also going to intersperse that with some, as she said, sort of use cases, patient examples of how this has been used and how it helped. And I do welcome any questions. I will be sharing the screen and doing things like that, so I won't see anything if there's a chat, but I'm sure that can be shared after or during. Joanne, jump in if you need anything that way from me.
You know I will.
Thank you. Great. Okay, so we're going to go ahead and get to the next slide, ideally. Here we go. Okay. I'm having some difficulty with, I am sharing my screen.
We're still on the first slide.
I see this. It is not advancing properly. I may stop and reshare. I apologize for the
no worries. Technology.
Gotta love it all the time. All right. Let's start with a blank screen and go to the presentation. Maybe that helps. Okay. So the next thing I want to talk to you about is how the platform helps care collaboration, because the key is many hospitals, nursing homes, clinics, anybody that would use our platform may be on very different EMRs. You may be in different health systems, but that doesn't mean you don't share the same patients. A lot of the time, it's hard when all you can see is what's going on within your EMR or within your system. And the idea here is that this is patient specific, not user specific as far as the information that you get. The patients are going to be identified through the ADT that we use with MyHint. We know that a problem that EDs have is throughput times, bottlenecking, delays while you're trying to look for information, or you may need to perform tests that end up being unnecessary due to a lack of information from outside of your facility. So identifying right away high-risk patients when they walk in the door so that you can plan accordingly and know why they're high risk. What information you need is given to you through notifications, and those are risk-based alerts. So any patient that meets the criteria will generate an alert to you that this is a special patient you should pay attention to. And that way you can activate the correct care team. You know who's part of the patient's care team. You may need to consult with a specialist and you didn't know the patient had one. They may have behavioral health treatments that you need to coordinate for their care. They may have been just discharged from a sniff, and you'll be able to see that, and share insights across care settings about this patient. So if there's something specific that is needed to know, for example, the nursing home would be able to put an insight in, and so would the hospital. So they can both put tips about this patient to each other that will generate a notification, showing the community the patient's involved with. The way that works in the ED is very simple. The patient presents, and as soon as their demographics are entered, it immediately, within less than a minute, will send the information straight to us, and our algorithm will check for any of the criteria, which I'll be showing you in a minute. And the ED will receive that notification right away, less than 2 minutes. That way, before you even room a patient, before the provider walks in to see the patient, they're going to know some things about the patient that will help guide their care and inform their direction that they might want to take. This is a very busy slide, but on the left-hand side, you'll see the notification criteria. So the standard notification criteria on the platform, you'll see that 5 or more ED visits within 12 months. Also, if the patient's going to multiple locations, 3 or more in 90 days, care insights, and that's the collaborative insights that I was talking about. Safety and security events, also a huge issue in the EDs, as you know, keeping the patient safe and the staff safe. So anybody that's had occurrences entered for perhaps they were verbally or physically abusive towards staff, or maybe they tried to self-harm, that way you can be on the alert before going to see the patient. You may need security around. You may want to remove things from the room the patient could harm themselves with, that type of thing. There are also readmission risk criteria that are added for this MyHint partnership, and the ED visit after a discharge, inpatient discharge. So if they're there inpatient and they get discharged, and really this is actually at any facility, so I do need to correct this verbiage. So if they were inpatient in a hospital and they show up to your ED, you'll be notified within that 30-day period, so you know that they were just inpatient somewhere, so that can help guide your decision making about how to handle that patient.
Nancy,
Also,
I'm
yeah.
sorry to interrupt, but I want to make sure that we get, I don't know if you can see the chat, but Brandon had a question about, like, who decides the criteria for how, like, for these notifications? Are these set at, are these preset? Are there's these things that can be designed by the department?
What I'm showing is just the baseline, the standard. We do have customers that have chosen to go that route and get into getting some custom criteria made. Maybe they have different time periods they want. That is something that is very customer specific conversationally. So we try to, when we're meeting with one of our customers, showing them about the ED solution, they can tell us what their pain points are, what their current initiatives are, and we can work on finding ways to make that more specific to them. What I'm speaking to now is just everyone will receive these items. That doesn't mean we aren't going to be able to work with you on something that you might need that you don't see here. Does that make sense?
You
Um,
are awesome. Thanks.
Yes, and I just pulled up, like I'm reading a couple different screens, so I apologize. I appreciate you
No,
letting me
that's
know
cool.
about chat stuff.
Yeah.
And yes, they may not walk in the door. I guess that is good verbiage correction. The patients, sure, they come in all the time by ambulance, by air, any way that they come in. But once they are entered into your hospital system, when they present there, they will be able to have these criteria generated for you. A lot of the time, without knowing a patient's care history, you may not be able to know what is a normal state for them. They may present abnormally, and then you may take a different route once you realize this is normal for this patient. And the notification does include a number of areas of as to why was this criteria, why was that generated for you. It also, this is an example of a PDF that you may get with some safety and security issues up top always, with some care recommendations. These are things that are entered by anyone on our platform about the patient. Hey, here's something special about this patient. You may get these notifications in a number of different ways. You may have a care coordinator or a case manager that may want to get an email with their notifications. You may have a printer with brightly colored paper that you dedicate toward notifications. But we also have trackboard integration. So keep in mind in an ED that you can have a trackboard within the ED, and then also for people that are outside of that department, other entities in the hospital that you might want focusing on specific patient populations, they can receive notifications too in a different way. Talked a little bit about that additional criteria that's specifically provided for MyHIN. These are the two that you would right away know that this patient had a nursing home encounter, that they were in a nursing home, so that if you're trying to work on throughput and discharge them, maybe they went home after a skilled nursing stay and they just failed at home, and that's why they end up back in your ED. You can contact that SNF and you'll know which one to contact and be able to more readily transfer them back there for streamlining your discharge. That does help quite a bit. And again, you can receive things in different ways. You can get the notifications delivered to you. That's usually the most effective in the ED, as it is real time. That will happen when the patient's there so that you can take action. But then again, logging into the platform directly is another way that people manage specific populations that are usually external to or more of a case manager role.
Nancy, there's a question. I don't know if you got to Trevor's question. The additional criteria beyond just the one set for MyHIN, is that only available for facilities that utilize the PCC platform? Because like care insights and safety aren't
Correct.
right now part of the normal HL7 ADTs.
Correct. This is for people that are participating in the PointClickCare platform here with MyHIN. So if you are one of the emergency rooms that we integrate into our platform, you can see all information that is coming in through the ADT feed, but it is also information that's curated. So it's information that is contributed, excuse me. I guess if you look down here a little, you can also see these next slide that I was going to actually has examples. You can see who entered it, when they entered it, for safety events, so that you can see historical, how much has happened with this patient. For this patient, that was one of the reasons that they got a notification, because there was a security event. So that is actually used by people because they're sharing this information across the platform. And not only does it help.
Ooh, sorry, Nancy, I'm so sorry. I just didn't want to miss the opportunity to say that one of the things that we really want to try and do to build out the offering here, Trevor, is to create, we have this thing called alert and query conceptualized as a use case. And it's sort of like once a patient is admitted to the ER, can the ER query MyHIN for other information that other people on the care team think is important to highlight? So basically to add to that criteria.
Correct. And it's a way that even within the same facility, for example, your ED may have things that happen with a patient that presents there, and that patient may show up back again at 2 a.m. and it sure would be good for the next person that sees this patient to know that information. So that does generate externally and internally. So all of the entities that are on our platform would be able to share that and also contribute to and modify that information. It is not meant for like sharing an entire med list or anything, but things that are germane to someone else caring for the patient, or maybe facilitating communicating outside of your facility. Example here, dialysis patient. So you can get them reconnected. Maybe they haven't gone and they need to, and you can call there and get them connected. Things that you may not know and the patient may not know, or may not, I guess, share that information sometimes. And it does, when I saw that question too about does this extend to pre-hospital? So EMS, if it's a community paramedicine program, yes, they can participate for an EMS because of the patient is only theirs for that moment. They're not actually managing a patient in order to need to continue to get notifications about what happens after they're done with the patient. So that's a whole different use case than an ED would be. So that's just a little bit of that. A notification, again, you're going to get alerts, you're going to get safety, security, care insights. These are all collaborative issues. You will also see an ED encounter account, as well as a listing of the various places they've presented, when they've presented, and what their diagnoses and chief complaint were, what they presented with and what they were diagnosed with, so that you can see if there's any trending with a patient, or if they've been going a lot in the past couple of months. You'll be able to see, and again, exactly externally, you'll be able to see what happens outside of your facility. You may have traveling patients, and therefore the care team's also helpful, that you may need to be able to contact their specialist. You may have no idea if they are on an ACT team that can assist with discharge. Then let's say you want more information, you'll be clicking on this link, and that'll take you right to the patient overview page, which I'll show you in a minute here. So we don't need that part. What we need is, here we go. That's an example of a track board notification right here. So it's just an icon, and it can be incorporated if you have a compatible track board. We also do EMR integrations with Epic and Cerner, and can work with you on various integrations that you might want to do. This is just an example again of our notification, and saying that you can just log in once you click that. So I'm going to go ahead and stop sharing so I can get into the actual portal. That
Nancy,
way you can.
Do you know Jonathan Jonathan Byte, F-E-I-T?
No.
Oh, did you know that he is sending pre-hospital data to PointClickCare in Oregon?
We do have nationwide. Oregon is very heavily involved in contributing to our network, as is Washington, California. We have a number of convener states. I live in Illinois, which is also a hospital convener state, where all of our hospitals are connected. So yeah, it is a nationwide network. So here's an example. While I'm pulling up the platform, let me just say, we have an example of a patient that she had hip surgery. It went really, really well. And then she had a really good recovery at a nursing home. But then 10 days later, she fell. So she ended up back in the ED. When she got back to the ED, she did get, everyone there in the ED got that notification that, hey, this is her history. She just had surgery and was just discharged within this 30-day period. That way they were able to recontact the nursing home and avoid an unnecessary rehospitalization. And they were able to connect her with a place that already had all of her information and had already cared for her. So that went very smoothly.
Are you showing your screen? Because we don't see it.
I am now.
Okay.
I'll just tell a little story. let's say you get a notification on this particular patient. This is an example. This is all fake information. So don't worry, I'm not sharing live data, but this is how it looks. And you will be able to use a couple of functionalities here. Let's say you get a notification because she's in a high-risk group. And maybe you're doing a homeless initiative. These are ways that you can identify patients that are in specific populations just by adding a tag for the patient here, which you can create within your own facility, depending on what you're working on and what you want to be alerted for. We talked about the care team here, so that again, the patient may not know who all they're involved with, nor might you know. So this is a way that you can see, okay, this is the nursing home they were in. Looks like they're at a pain clinic. They're here for some opioids, so let me give them a call. It's just ways to know. And also sometimes providers need to collaborate with other providers, and this is just a good way to surface that information from outside of your own entity. We talked about the encounter history, being able to see where and when they presented at various places. A lot of the time it'll pop up, different insurance plans they have, what they were diagnosed with, where they were discharged to. Just gives you a little more information here to see trending. So that you'll have, and you can also custom select different dates for this if you want to minimize or maximize how much history you want for the patient. These are the insights we were talking about. Not all states have insights. Some of them have guidelines where they enter things that are entered by providers versus being entered by everyone in the same area. So here is how it would look. You would be able to enter descriptions of, hey, this is an unusual presentation for this patient, but that's normal for them. They are in a program with an ACT team. Here's the information. There may be attachments that people want to share. They may record some history so that is flagged to people that these things have happened. Again, this really helps. Maybe they have a specific discharge plan, maybe they have a pain agreement, and that will help give some insights into what their restrictions are for what they're supposed to be taking. And then we talked about the safety and security events that, again, and these are entered by users. So you would select what type of event happened and then type in your details. Get back out of here. And that will allow you to see like when and where things happened. But this is a way to share with others as well as share back to your own staff when the patient represents that, hey, this happened last time they were here. And then we do have abilities to do various attachments here. Some, again, the post form, special health needs, we don't, so this lady has a pain agreement attached. A PDF, you can also attach, like I said, things like post forms and what have you, things that might be hard to dig for in an EMR that you really want to make sure people have. So the ED getting these insights for things that they don't have within their own EMR, that is a really big feature. We also had a patient that had advancing CHF. He needed a lot more care, so he decided to move from California to Illinois, and he moved in with his daughter from out of state. So he moved in with his daughter. Then he ended up in the hospital in Illinois after he moved there. And he was discharged back to her. Once she discovered that he really needed too much and she couldn't handle him at home, she had him go to a SNF. So after he was in a SNF for a few weeks, like 2-3 weeks, he had decompensated to the point where they had to send him to the ED for his CHF again, but they sent him to a different hospital because it's closer. So that enabled those notifications to happen. So even though the patient had never been to that ED, they could see all of his history and information and thus help coordinate care to prevent a readmission in that case. So they knew that he needed more care. They knew that he was involved with the sniff, but they didn't know that he was at another nursing home. At another hospital previously. So that's another instance where it really, really helped. I have a number of areas that I can show you here. Scheduled reports are reports that you can always customize and run on demand, but you could also have your staff monitoring. Sometimes they sometimes a director of the ED would want to see what has happened over the weekend or wants to see what happened, run the numbers for last week. Maybe just a disease specific management report. These are customizable reports that you can request. Groups are something that you have the ability to create for your facility. So yes, you're going to be able to do these reports, but maybe you want to do patients that are homeless or high risk, high utilization patients. So you can tag those patients and that way you're able to sort them. You can export those patients for being able to manage them off of a desktop outside of the app too. So that's just an example of what this hospital did that created these different tags for patients and what they did. So this one has a pain agreement. So that's just another patient example where these are tags for this patient that she has. So the pain agreement tag here, let's say she didn't have the pain agreement anymore. You can easily remove that and manage that population without her on that list. And then add in tags the same way. So that's another way to be grouping patients to receive information about them. So here we are talking about the post forms need to be accessible in the field. Yes. So basically the statewide interoperable registries and the nationwide, all those things. So a lot of places simply have that paper post, and that is all they had to work with because there isn't a registry, for example, in my state. So that's kind of what that is. A lot of the time, there's giant packets of patient information that go back and forth, but that may not be findable in the stack, or it may not be the most current one for the changes that were just made with the patient. We do have quite a bit of success with population management for initiatives that involve care coordination and follow-up. So specifically following up on patients that are discharged within a certain amount of days. That's kind of where these scheduled reports go for follow-up. The notifications is the big thing that you want for your ED to get right away through the ways that work for you. But you'll be able to see their current status, where they've been discharged to, those that have active insights that were authored, those that had criteria met. And here you can see this patient has been to multiples, but you're wondering how many times have they been to different hospitals? Well, that's how many they went to all these different places. That's sometimes helpful in managing patients that go to a lot of places. And you can view these without opening the patient specifically, like we did with Sally. You may get a late lab result, or you may find a critical value that you need to contact the patient for. And this phone number here isn't working for you. You're also able to look there and see all the numbers that this patient has presented at different facilities, so that if someone needs to call the patient, they could try these various numbers. As we know, the high-risk patient population often is difficult to reach. They're seeking care many places, and they may be staying with their sister one week, staying with their mom another week, and that helps us to try to track them down. So usually to help for case management. Let's see. What else here? Okay, I guess open it up for questions. Is there anything that someone was wondering about or wanted to see, or questions about the function?
Do you guys, and would it work the same for advanced care plans, advanced care plans?
Well, advanced care planning, if they didn't have a post form, you mean like power of attorney for healthcare, that type of thing? Yes.
Right. Mm-hmm. Okay.
Yep. And anything like that can be used as an attachment. Anything that's a longer document as well. Sometimes those power of attorney for healthcare can be kind of lengthy, but yes, those can be attached on here too. So it's just a matter of what the specific use of the facility that is using it would want to do. Those are down a little lower under attachments, but you can attach them within here or just in general below here.
I'd love to ask the group here sort of why they came, sort of what is working for them now and what isn't working, or what information do they need made available when their patients enter the ER? What were they hoping, to come here and find out? And have we answered those questions? Is there more discussion about, about what other clinical providers might want to make sure that ERs see? Jonathan, come out of the chat. Come talk to us about how this works for you. Will you? No.
Sorry, too many buttons to hit to get back from that. Hi.
Hi.
Sure. So my name's Jonathan Fight. I am clearly shy and quiet. Don't have anything to say.
You really are. You're my type of dude.
Thank you. I appreciate it. At least there's someone out there. Someone for everyone. So I run an organization called Beyond Lucid Technologies, and we specifically focus on interoperability with ambulances, which is why that my focus is there. But as I mentioned, I have the privilege of working with PULSed and special health needs documentation and interoperability specifically across the state of Oregon. And there we have been working with Collective Medical, which was the specific PointClickCare system that was being shown on screen here, right? I'm happy to address anything specifically that I can, but my point was that one thing we find is really quite problematic, and it came up. I think Nancy made the point a bit earlier. I'd be more than happy to talk about community premedicine. By the way, Nancy, there's a lot to say there, and I work with programs in 7 states at least off the top of my head for those. Happy to talk to you about it. But I'll give you an example. There's a big hospital in Southern California that is very well known. I won't mention their name here because I think this is being recorded, but believe me when I tell you, you'd know their name, and they're in the Los Angeles area, so we can sort of narrow it down. This particular institution has an emergency department that brings patients in from all over the Southland, as they call Southern California. And at one point, I had the ability to ask them about their PULSed, the end-of-life medical orders that their patients may bring in. And their answer was, well, we have our PULSed forms attached to the EHR platform. They use Epic at this hospital. And so if, patient is admitted, if the patient is getting cardiac care or whatever other, they're in the ICU and they have an end-of-life order, they have access to the PULSed within the platform. At which point I pointed out, but your emergency department receives ambulance transports from all over Southern California. What if your patient was previously at another hospital? How would you know? Again, to Nancy's point about the printer that has the brightly colored pink or yellow paper or whatever. And their answer was, we should probably look into that. Yeah, you should. The ambulance is the one that goes to the patient, right? If all of the information is being accessible inside an institution, whether it's institution specific, signed onto a certain platform or whatever, then the folks who are going to the truck, in the trucks to the patients, or even as part of a community paramedicine program, which there is exactly one state presently whose CP programs have access to Pulsed in real time on a statewide basis. And again, those are CP programs in Oregon. So to the degree that closing these information gaps will help patients, particularly in moments of critical need, certainly there has been enormous value in being able to send data into the emergency department information exchange that Collective Medical runs, for example, and to be able to send data to and from health information exchanges directly in several states. So my passion, I guess, and why I was speaking up is the fact that most people seem to not realize nationwide that ambulances don't have native access to most of that information. Ambulances use a different technical language. They use their workflows are quite different. They don't have direct access in most cases to health information exchanges, with very few exceptions in places like Colorado. There is exactly one service that has submitted data to the health information exchange per se in Oregon. I won't go into how I know that, but let's just say it's there. And now finally across the country, more and more HIEs are starting to say, if we have information from the ambulances and we have the ability to send data back down, then they can have this relationship with platforms like PointClickCare's software to be able to make sure that data are current and distributed, but that includes the ambulances as well. And so I always want to make sure that people realize that ambulances don't have access to everything that hospitals do, and they have access to a whole lot of stuff that hospitals don't have. So crossing over that line between the pre-hospital, also post-hospital, to Nancy's point about community paramedicine providers, and the hospitals and their platforms, including health information exchanges, would close a critical gap that has been banged on for a long time by a lot of people, including some very smart folks at Audacious Inquiry, who are, of course, now part of PointClickCare. That is, if you have anything else you wanted me to add, Joanne, I'm more than happy to, but that is the hill I will die on, is we need to start bringing the ambulances into the fold.
You want to know what's funny? When you started talking, and even just now, I was like, oh, wait, I've heard this before. So I found you in my inbox. So like, this is something that MyHIN is really interested in working on. And we've been, I know that you've been meeting with people. I have a question for Nancy, just about, like, not just about ambulances, but about transportation in general. Could you also, I'm assuming you could also see, like, if a patient, if a patient doesn't have access to transportation, or if they don't have a home to return to?
Ideally, yes, because we are counting on for contributions about those things. Those insights, those care insights, the new format we have does have an area for homelessness and housing security. And that is where we would find that information. We've also, you saw those, the house icon on the trackboard on the dashboard and on the patient themselves. And then on the care team, that is community entities also. So you could add the shelter that they stayed at, or you can add their community care worker, things like that. So there's a number of different ways to utilize and surface patients with social determinants of health using the platform.
And MyHIN actively, the way that we work is by tracking active care relationships, creating care teams, understanding who can get what information when, and what information, a patient wants to be shared. So if ERs don't currently have this information, what do they have?
Yes, hi, this is Cody from West Michigan. How are you?
Hi.
Hi, I'm with Oakland Hospital in Marshall, Michigan. Right now we are connected to MyHIN. We're not using it to the extent that you demoed today, but we use it for the Bamboo Health notifications, which was previously known as Patient Ping.
Patient Ping, yeah.
It's been a lifesaver. We've been using it since we were on the APM CPC Plus in 2017. But my question is this platform connected to the Commonwealth Health Alliance that started quite a few years ago, that many health systems already have established through their EMR? and spent quite a bit of time standing it up. Does this backfeed off that in any way, shape, or form?
Yes, and on the patient overview page, there is a button that says CCD on it. So if you do use that platform, it is integrated, and you would be able to access all that right within the patient's information there. For anybody that participates can view the CCDs.
Okay, great. Thank you.
You're welcome.
Nancy, I see a lot of different, I see people that are a lot of in different sort of sectors of the care ecosystem. Do you work with payers?
Yes, we've got all payers, including all government entities, are on our platform and integrated. And that's a great point, because a lot of the time there is a specific on the high risk patient populations, there may be a specific case manager assigned to that patient, and they would be in the care team. Also, with those entities, the health plans that are integrated, a lot of that information, not only the real-time information, but also the historical information is brought into the platform from them. And they also are able to see the patient activity and the insights, and they do utilize that, especially when they're talking about behavioral health. There's a lot of case management involved there.
Great. Anybody else have any other specific questions, or somebody's asking about your work with tribal health entities?
That I will have to plead ignorance on, but I certainly can find out.
Jonathan, tell me more.
Yeah, so I think that the Commonwealth question, I think it was Cody, right? Was the fellow who said that from out there?
Yeah.
So let me throw a small plug in for the state of Michigan. I'm not from Michigan. I live in California. But my organization was the first from the EMS community to join the Commonwealth Health Alliance back in 2015. And it was the same year, if I'm not mistaken, that the states of Michigan and Texas became the first states to join on effectively a statewide basis to join the Commonwealth Health Alliance. So certainly Michigan has been on the front edge of interoperability for a long time, as has the organization I work with. The reason I wanted to speak up about this, and I think there is something here that Nancy kind of glossed over, but I think it's worth talking about when you start looking at the ability to crawl over systems and pull things into a unified platform. For example, leveraging a pre-hospital HIE and or an emergency department information exchange. And that has to do with patient ID matching. So one of the big challenges, huge challenges in emergency medical services is that you may not know who the patient is, right? EMS, mobile medicine in general, is the only sector of the American healthcare system, and this is a pull quote, bold underline thing, that routinely deals with the unknown patient, right? Whether that is because of substance use issues and the patient's overdosed, or because of a car crash and of a traumatic injury, or because the person's out of their mind and they tell you they're John F. Kennedy and they're just not, right? So for so many reasons, the trust factor of who this person is, and therefore how do I look them up in a health information exchange or in the EHR and not have to put them in as a John Doe, is actually a really big deal, right? That's a big stopper on a lot of the interoperability initiatives. But that's starting to change. And so Commonwealth is one that put some blocks in place contractually many years ago that essentially said you needed authorization in order to be able to look up a patient, and they needed to be of sound mental status, state to be able to give you that permission. With TEFCA and some of the new interoperability initiatives, those barriers are coming down. And so the ability to utilize different platforms, including the one we're seeing here, to essentially say, show me all the different places that this person may have touched the ecosystem, which can help me to confirm that I'm looking at the right person. And so when Nancy, you mentioned community paramedicine, and this is part and parcel of CP programs, right? Because the programs are more controlled. But as we know, that a patient who is in a community paramedicine program is being managed, but at the same time, they may have more encounters with the healthcare system than the CP organization is aware of. And so the consolidation of their encounters, even between the community paramedicine visits, helps you provide a more informed longitudinal care than you would even if if you had access to any one institution's data. You kind of get to open the tent and see things that you otherwise would have missed in between appointments, so to speak. And I think that, and again, Joanne, that has big implications for longitudinal care and managed care across a lot of ecosystems, especially in high risk, chronic or acutely, chronically acute patients, as we